Good evening, I'm Bill Watkins.
I'm the Medical Director at Tas IVF. What I'm going to be doing tonight is just giving you a really brief introduction into fertility matters. Everything's relatively superficial without too much detail on any one topic in particular. If you've got any questions, there should be a little spot over on the right-hand side of your screen, which should allow you to ask some questions, which I can digress on the topic and answer if you wish. You'd probably rather look at some pictures than me, so I will show you a few slides as we go along. Okay, hopefully this should come up. First of all, if you're planning a pregnancy, you need to be in the best possible health you can be pre-pregnancy. There are a few obvious things that we should and shouldn't do. Firstly, pregnancy vitamins. It's really important to take a pregnancy vitamin before you start trying to get pregnant. And the two most important vitamins we know of are folic acid and iodine. Those two should be present in almost all the preparations you can get from your chemist. But if you're in any doubt, just check with your chemist. Weight's important. Obviously, you want to be in an ideal weight range if possible, but also weight's important. If you are a larger lady and have a body mass index of over 30, it's probably worth taking a bigger dose of folic acid. Again, the simplest thing is just talk to your pharmacist about that. They should be well aware of these issues. The don'ts, obviously alcohol, smoking is clearly bad for your general health and will interfere with your fertility and obviously the health of your pregnancy. From the guy's point of view, we need them to be fit and healthy as well, ideally not too overweight. The guy on the screen there has obviously been taking some anabolic steroids, which will be bad for his sperm count. But generally, good health is essential leading into the pregnancy. It'll improve your fertility and improve the health of your pregnancy. This is just to give you a rough idea of where you might stand. These are general figures and you can't quote them exactly. But if you're a young woman, we'd say that somebody who's under 30, you've been trying for 12 months, or really we should be looking at off contraception. When we ask patients, how long have you been trying for pregnancy, they'll often say, oh, only 6 months. And we ask, when did you stop contraception, meaning stopping the pill or stopping using condoms? They'll say, oh, 2 years ago. And it's that length that we're looking at when we're looking at these statistics. It's really how long have you been exposed to the chance of falling pregnant, not how long you've been actively trying with apps and timing of intercourse and things. So if it's been a relatively short period of fertility, say no more than 12 months, certainly less than 3 years, then your chance of pregnancy in the next 12 months, if you do absolutely nothing, is roughly 1 in 3. And your chance over the next 3 years, which now means it's a total of at least 4 years you've been trying, is about 64%, 2/3 of patients. That's probably a lifetime chance of pregnancy. If you don't fall pregnant in that 4 to 5 year period of time, then you're unlikely to fall pregnant without assistance. But the good news is with assistance, we still have very high success rates, fairly much irrespective of the length of infertility. Depends on the cause of the infertility. Here's an important factor again. This is the age factor. Now, it's not like you turn 29 one day, 31 a couple of years later and suddenly your chances change. This is a gradual progression. So if we look at people over the age of 30, in the next 12 months, the chance of pregnancy is roughly 1 in 4. The chance in the next 3 years is now below 50%. Obviously, you wouldn't apply this to somebody who's 42, 43 years of age. So you can see that as people get older, their fertility declines, not startlingly new news. Here's the other factor as well. This is where we've kept the person over the age of 30, but we've increased the duration of their infertility now to 3 years, 36 months. And you see there, the numbers really start to plummet dramatically. So this brings out two really important factors: how old you are and how long you've been trying. They're two things that have really very significant bearing on the chance of there being a problem and the chance of us needing to help you out. And they're actually two of the most important questions I ask patients. Okay, so why aren't people falling pregnant naturally? 1 in 6 couples need assistance. Age is a very important factor in this. The female-related factors are generally ovulation problems, tubal disease, male-related problems, which often low sperm counts or can be problems with sexual function. There's often a combination of factors. Often there's no really major factor for either partner, but the two minor factors contribute to making it difficult. Often we end up not being able to give you an exact answer, and sometimes it's a matter of when do we stop expensive invasive investigations and just get on with some treatment that we believe will work. Okay, so when do we investigate? The obvious one, the one that most people would have heard of, is 12 months of unprotected intercourse, meaning off contraception. But there are clearly situations where we should investigate earlier. If you're over 35, we'd generally recommend investigating earlier, maybe in 9 months of trying. If there's previous infertility for either partner in a prior relationship, that would be an indication to perhaps investigate earlier. Some of the early investigations we do are very simple, inexpensive, and can give us a really good picture as to what might be going on. If there's a history of chlamydia or any other sexually transmitted infection in the past, it may be worth investigating earlier. If the male partner has had an orchidopexy, that's where boys are born with undescended testes. They're much more likely to have a sperm defect and really should all be tested. I actually encourage anybody who has had this operation in the past as a child, even if they're not planning a pregnancy now, to get a sperm count done, because sometimes the sperm counts can be very low in these men and they may go to 0. And if they're low, we can freeze sperm, and then it doesn't matter whether they want to try and get pregnant next year, the year after, we've got sperm. If the cycle's irregular, then we should certainly investigate earlier. If somebody's not ovulating, if they're getting periods every 3 to 6 months or not at all, there's no point waiting 12 months because there's no chance of pregnancy. Previous chemotherapy, if you've had chemotherapy as a child or a young adult, and your cycles may well have returned to normal, which is great, but you almost certainly have a reduced ovarian reserve. Your fertile window will be narrowed. So we'd strongly recommend that anybody who's had previous chemotherapy and is planning a pregnancy, whether now or in the future, that they do see a qualified fertility specialist. So what happens when you come along? First of all, remember you do need a GP referral to get Medicare rebates for your consultations. The first consultation should be fairly non-invasive. It's getting a full history, medical and fertility, assessing general health issues, and organising some basic tests. What sort of female fertility issues are there? As we've mentioned before, flick over this pretty quickly. Blocked or damaged fallopian tubes, polycystic ovarian syndrome, endometriosis, the presence of fibroids, or failure of ovulation to indications other than, or diagnoses other than polycystic ovarian syndrome. Now, if you think of the bare essentials of what you need to achieve a pregnancy, that makes the investigation process fairly simple and straightforward. 1, you need eggs. 2, you need sperm. And 3, you need the correct plumbing. You need the fallopian tubes to be intact and functioning well. And so that's how we investigate all these cases. And we break it down those 3 simple areas. So if we look at the eggs, what do we do for eggs? We like to test progesterone levels. Now, there's a correct time in the cycle for the mid-luteal progesterone level to be done. It's not 7, it's 7 days prior to the next expected period. It's not classically the day 21 progesterone that everybody talks about. We talk about a day 21 progesterone, unfortunately, because most people have a 28-day cycle. But if your cycle is irregular, and say you've got a 35-day cycle, then you're probably ovulating on about day 21, and your progesterone level wouldn't have gone up by now. It starts going up when you've ovulated and peaks 7 days later, which is 7 days before your period's expected. So we do the progesterone level 7 days prior to the next expected period. Obviously, the cycle is very erratic. There's no point doing that because you won't know when that day is. What we do is an AMH level, anti-Müllerian hormone. That's a really great measure of your ovarian reserve. So as people get older, their ovarian reserve declines. Some women, their ovarian reserve will decline earlier than expected. And it's a really good test to have. It's perhaps a test that all women between 25 and 30, particularly if they're planning on delaying a pregnancy, should have to see what their ovarian reserve is like. Those, sorry, a couple of these slides have managed to be repeated. Okay, this is the AMH level, and you can see here on this graph, when you're born, this is how many eggs you've got left. You can see you've actually lost most of your eggs already, or at least half of your eggs already. By the time you reach puberty, you've lost most of the rest of the eggs, And these are the eggs that are left for the reproductive phase of your life. And remember, most people are now trying to pop their babies in here when we've really lost most of the eggs. We can't change that, unfortunately. When you have this AMH test done, you'll be given a number, and we look at your age along the bottom line, look at where that number is, and see which region you're in. We'd like you to be up high. Now, sometimes you get a result through another doctor, and they'll say, "Oh, look, you're very high. You're greater than 75%. You might have polycystic ovarian syndrome, and that should be a worry." It's not. Look, the more eggs you get from a fertility specialist point of view, the more you've got there, the better it is. Okay, there may be some issues with polycystic ovarian syndrome, but we'd much rather deal with that sort of a problem than where there's a lack of eggs. Okay, this is a diagram that I had drawn up by a well-known Tasmanian artist, Tom Samick, to try and explain to you what your ovaries are doing. Basically, this is the ovary producing eggs. Now, right from the time you're a fetus, you start producing eggs, and they come online. They get onto this conveyor belt. This conveyor belt takes about 90 days to run. There's a little mechanism here that each month normally goes around and picks up one egg, and it ovulates. Here, the mechanism's disengaged because this is a pre-puberty picture. So you're still using up eggs. You remember that graph that showed those eggs declining? Because eggs start growing and they continue to grow until they've run out, but they don't mature. Here at puberty, this mechanism clicks in, and this scoop goes around about once every 28 days in the average one and leads to ovulation. Meanwhile, there's still other eggs going along this conveyor belt. Nothing stops that chook from putting more eggs out onto the conveyor belt. Okay, by the time we reach reproductive age, there's not so many eggs on that conveyor belt, but one will be picked up and multiple will be lost. And once they start this journey, there's no way of stopping them, and they'll reach a certain point, and if they haven't been the lucky egg, they'll become what we call atretic and basically die off. As people get really old, this is Tom's drawing of a really old, you may still get the odd egg, but it's not a good normal egg. Okay, let's move on to semen. We'll skip through this pretty quickly. For guys, the sperm test is pretty straightforward. We need a sperm sample, ideally collected at the laboratory. If it's collected outside, it might get warm, it might get cold, and that'll give us an incorrect result, potentially. But there's a few things we look at here. We look at the volume of sperm, which can vary dramatically. This is sort of an average mid-range. Motility, we like to see at least 25% of the sperm rapidly motile. Good sperm progression, meaning the ones that are swimming well. The concentration is probably the most important one. As long as we can see some sperm, we have a good chance of getting people a pregnancy. We don't, with modern techniques now, we don't need lots of sperm. We can have basically one sperm per egg. Morphology is the shape of the sperm. This is one that worries people a lot. They'll often get a report back saying they've only got 1 or 2% normal sperm. They worry they're going to have abnormal children. It's got nothing to do with this. This is with that. It's just the shape of the sperm. And the laboratory are reporting the ones that are basically perfect and they can't fault. It's like having a car with a scratch on the Duco. It still functions perfectly well as a car, and these sperm will function perfectly well as sperm. If you get too many dents in the car, though, perhaps it's not going to function so well. So when we see very abnormally shaped sperm with lots of abnormalities, there probably is a fertility factor involved there. But this is not going to cause abnormal children to be born. We also want to check for antibodies. It's called an IBT. Sorry, it's not perfectly aligned there. And we check for the presence of anti-sperm antibodies. You can make antibodies to your own sperm. The immune system is effectively fighting your own sperm, and that can be a significant fertility factor in some men. Then we get on to the plumbing, the fallopian tubes. There's a number of ways of assessing that. We do an ultrasound, which can check the pelvic anatomy. It's also actually a good test for the assessing the ovarian reserve. It's an alternative to doing the AMH level. And say occasionally you'll see fallopian tubes on ultrasound. When you do, it's because they're damaged and significantly abnormal. But an ultrasound should form part of our basic workup. Often it's not done on the first consultation, but sometimes it is, or it's done in a subsequent consultation. And this is an ultrasound of some ovaries that are what we call polycystic. They're not actually cysts. These are just early eggs there's just masses of them. And this is what a polycystic ovary looks like. Here you've got our chook again with masses of eggs. The mechanism here is jammed, and needs to be fixed up to get this scoop going around again. And that's what we do. Here's our helping hand, usually in the form of just some simple medications, often just tablets, and lo and behold, everybody's happy again and ovulation's happening. Tubal patency tests. There's a number of tests we do. One is called a hycosi. That's the modern form of the hysterosalpingogram. Hycosi is an ultrasound test where dye is put into the uterus. They do ultrasound to see if they can see the dye spilling out through the tubes. Again, you don't see a normal tube on ultrasound. Hysterosalpingogram is perhaps the older version of that. It's done in an X-ray department with X-rays and radio-opaque dye. That's a fairly unpleasant procedure at the best of times. We much prefer doing hycosis nowadays. Sometimes we'll also do a laparoscopy. A laparoscopy is an operation where a telescope's placed through the belly button so you can have a good look down into the pelvis. You're asleep at the time, of course. Dye is put in through the vagina into the uterus, and we see if the dye comes through the fallopian tubes. The advantage of that is you have a very good look at the tubes. You can potentially treat anything that you can see that's abnormal, but it is a much more invasive test than the other two. And you need to be sure that the laparoscopy you're having is actually going to advantage you and give you some useful information before you have it. So on follow-up, we should be able to give you the test results. There will be other blood tests you have, but we won't go into all those tests. We'll then be able to give you options for treatment, create a treatment plan, and commence treatment whenever you're ready. You know, your fertility specialist should be able to tell you how urgent this is without making you panic, and just give you an honest assessment of what you should be doing. So what are those treatment options? Now, this first one seems a bit silly. Wait. Sometimes that's all you need to do. We find nothing wrong. If it's a relatively short period of infertility, the best advice you can possibly receive is just to wait. Often patients are wanting active treatment as soon as possible. Other patients are not. They're just wanting some reassurance that everything's okay. It depends on where you are. But a good fertility specialist will be offering you the least invasive form of management that is likely to lead to a pregnancy for you. And it's often not how many tests you do or how high-tech you can go with straight-up treatment. Our aim should be, with a good experienced fertility specialist, to use the simplest treatment possible for getting you a pregnancy. Sometimes we simply use cycle tracking. It can be very stressful going through multiple cycles where you're not achieving a pregnancy. You've been doing timed intercourse. You've used LH predictor kits, sometimes those crazy saliva predictor kits. And sometimes just stepping back, letting us just confirm that your cycle is working normally. Sometimes we'll even give an injection to make ovulation happen at a certain time so you guys know when to have intercourse, and it can just de-stress. That's really just where we think there's nothing much wrong. We just need a bit more time and we'll make it, but it's becoming stressful for the patient. Obviously, if people aren't cycling, this is probably the easiest and the most successful form of treatment, ovulation induction. So if somebody has polycystic ovarian syndrome or some of the other forms of anovulation, this is often very simple treatment. In most cases, it means tablets for 5 days at the start of each cycle. We usually recommend a scan before ovulation to check that there aren't more than one, there's not more than one egg developing, and then we can give a prediction of when ovulation will happen. Ovulation can also be improved by lifestyle changes, so we shouldn't give up on those. Changing diet, losing some weight. Sometimes people need to actually gain a little bit of weight if they are too thin or if they're doing too much exercise to reduce exercise. You may have heard of metformin being used. FSH is the injectable form of medication. That's one where the risks of multiple pregnancy go up very significantly, and we don't use that one quite so often anymore. We may move on to artificial insemination, where again we'll just track the cycle, we'll trigger an egg to ovulate at a set time so we can make sure a good amount of sperm put into the uterus at the time of ovulation. So basically we're increasing the contact between sperm and egg. Then we move on to the more high-tech ones, which we'll briefly talk about later. IVF, in vitro fertilization, and ICSI, intracytoplasmic sperm injection. And sometimes surgery is still useful. Probably the best example of that is if somebody has had clips put on their fallopian tubes because they've finished a family and have changed their mind or started a new relationship, surgery to remove those clips and rejoin the fallopian tubes is a very successful procedure in most cases, providing the sperm count's normal. And it means you don't have to see a doctor anymore. You have the operation, you go away. And a very high percentage of patients will become pregnant. Unfortunately, it is a bit of a dying art. Not many of us still perform that procedure because it does take a fair amount of training to do. Okay, so let's move on to these two now. Here's our egg, again, our chook with our conveyor belt. You can see a nice little number of eggs on there. We want more than one egg if we're going to do IVF. So that's why we give injections. When we give these injections, what you have to realise is we're not squeezing the chook. We're not making you run out of eggs any quicker. What we're doing is by giving you the FSH injections, giving you more follicle stimulating hormone, we're sort of broadening that scoop. So we're picking up more eggs that otherwise would have just been wasted. I have had this diagram redrawn, I just haven't scanned it yet so that the scoops come across the conveyor belt. And so with IVF, we're not using up more eggs, we're just collecting more eggs, and these are eggs that would have otherwise been wasted that month. Here we just show, as people get older, there's not so many eggs on that conveyor belt. So sometimes it doesn't matter how much you increase that dose, you know, how broad you make that scoop, you're not going to get any more eggs. Okay, this is a quick little video. I'll show you part of this video if it'll play. Let me go back. It's not wanting to play. That's unfortunate because it shows an egg collection. But this is an ovary that's been stimulated. When we do the egg collection, this is the top of the vagina here, and this is actually a very short distance, less than a centimetre, and bang, we're straight into the ovary, and we can collect those eggs. We just aspirate the fluid. This one is going to work, so that's good. So here you can see it happening. Here we're doing the scan, we're moving around, we're looking for the safest spot to enter into the ovary. And in a minute, you'll see the needle come down along this line. We won't waste too much. Here it goes, there it goes. And what's happening now is we're starting to aspirate, and you can see that follicle getting smaller and smaller as the fluid goes out. We're trying to keep it centralized. You know, some people here have done more than 10,000 of these. So once you've done 10,000 of them, you tend to be pretty good at them and pretty quick. So this is all happening in real time. We haven't sped this up at all. So we go into the next follicle and we just slowly aspirate. How long the procedure takes depends obviously on how many eggs. You can see if you only have 3 eggs, well, the procedure's just about finished. We hope to have more than 3 eggs if we can. Okay, so then all that goes off, the eggs go off to the lab, we get a sperm sample, we fertilise the eggs, and then hopefully we get some embryos after that. There's many options in that whole process. We're not going to go through those on this occasion, but hopefully then you come back for an embryo transfer. Now ideally embryo transfers are done under ultrasound guidance. Let's hope this video works because it's a nice video and it can't play media, it's telling me that down there. But what you see here, we see the little catheter come up into the uterine cavity. This is the whole of the uterus, this is the endometrial cavity. We're scanning from the tummy down into here, and we'll see a little flash as the embryo with the fluid it's associated with enters the uterus up here. Sorry, we can't show you that one. Then hopefully, it's not going to show us this one. This is a pregnancy. This is taken at about 6.5 weeks. From the start of the cycle. This is not twins, that's what we call the yolk sac, and that's the little fetal pole, as we call it there. So that's the little baby growing there. Okay, so what's new at the moment? One, it says IVF, we've set up a simplified IVF. We know IVF can be very expensive, and a big expense is the hospital bed. The cost of being admitted to a hospital and having an anaesthetist. We now do a simplified model where we don't admit you to hospital, we just do the collection in our treatment room as we do all the collections. We aim for a smaller number of eggs. We'd aim here for 8 to 10 eggs. Normally we'd be aiming for 10 to 15 eggs. And if you're only aiming for 8 to 10 eggs, you can do that egg collection really without an anaesthetic. It might sound terrible, but my preference is to do pickups with a minimum of anaesthetic. It's, I believe, safer for the patient for a number of reasons, which I won't go into now. But it's a very safe procedure. It's makes the cost savings quite significant. Yes, we would think we get peak pregnancy rates with egg numbers between about 10 and 15. So we may be slightly shy of that. but it's a really good option, and particularly for patients who don't want to be filled up with lots of hormones. And they say, "God, I'm happy going for a smaller number of eggs." Preconception screening, there's now many genetic tests you can have done. You know, you can have a test where you literally screen for 500 to 600 different genetic disorders. You really need to talk to your doctor about that as to see which sort of tests are right for you. We often recommend screening for conditions such as cystic fibrosis. These are sort of common conditions within the community that it's very hard to pick up on a family history, but that's a very specialised area which you should discuss with your fertility specialist. PGD, PGS, pre-implantation genetic diagnosis, pre-implantation genetic screening. That's basically where we grow our embryos. When they get to the day 5, the ones that are suitable, that have grown enough, are biopsied. We take cells off and get the cells genetically tested. That's particularly good for conditions such as cystic fibrosis, where we can check to see which babies have inherited which embryos have inherited that condition, and we can choose just to transfer the normal embryos. We can also screen the embryos if people are having repeated miscarriages, for instance. We can do pre-implantation genetic screening just to check that the right number of chromosomes, the genetic material within the embryo, is correct. And if we do that, we can certainly improve our pregnancy rates per transfer. Obviously, though, we're not making an embryo normal, so we're not going to get more babies per egg collection, but we may be able to help people avoid the traumas of having miscarriages. Vitrification is a new method, well, relatively new, it's been around for a while now, of freezing eggs and embryos, and it really has made a remarkable difference. Unfortunately, we still have many hundreds of embryos that are frozen with the old method. This new method, though, is significantly better. We get much better freeze, thaw, survival rates, and the implantation rate of those embryos is better as well. We now have numerous consultants working with Tas IVF. There's myself, Bill Watkins. I've just been doing fertility work now for 25 years, nothing else. We have Manuela Toledo, who comes across from Melbourne to do some work. Steve Sonneveld, who's been with the practice for many years. Steve Bradford, and most recently Emily Price, who's joined. We often run a Saturday morning clinic. It's really important, I believe, that both partners are present ideally as much as possible, and particularly on the first consultation. It's important that the guys are kept involved in what's going on. And so sometimes it's not possible for the guys to get away from work, or for both parties to get away from work at the same time. And Saturday mornings can sometimes help out. So if you're thinking you need to have your consultation on a Saturday morning so your partner can be there, let us know. We don't run them every morning, but we do when there's demand. There's also nurse consultants. Our nurses have many years of experience. I was trying to add up how many years of doctoring experience we have at Tas IVF. It's over 50 years between us all. And our nurses would probably be more than that. A lot of nurses with a lot of experience. And if you like, you can have a 15-minute free consultation with a nurse. If you think coming in and seeing a doctor and the technicalities of what might be thrown at you at that point is too daunting, have a talk with one of our nurses. They are very experienced and very happy to help. Now, if there's a take-home message, what is it? I think it's time taken versus time remaining. Two critical factors. The time taken basically is how long have you been trying and not succeeding? And the longer that is, the more likely it is that there's a significant problem and we need to get on and investigate it. It may be a very simple solution at times, even if it's been a long period of infertility. I think the longest I've had is 17 years of infertility, and we had her pregnant 2 months later. The other really important factor is time remaining. How long have you got left? And there's two things that determine that. Firstly is how old you are. Obviously, if you're approaching 40, we're on a tight timeline, and particularly if you want to have more than one child. The other factor is that anti-Müllerian hormone, the AMH blood test we did. Some young women can have a relatively short period of time remaining. So it's really worthwhile considering getting that test done, even if you're not planning a pregnancy now. If you're planning to delay for a few years, get that AMH done. We can freeze eggs if we need to. So why choose Tas IVF? We've got a huge network of care now. Our parent company is now international. We have clinics throughout Australia and also overseas. We have a large number of scientists who work with us. There will never be a shortage of scientists. We've always got backup. and some of those scientists have again been with us for over 10 years and have a lot of experience in IVF. As I said, we have a very experienced nursing team. They're always happy to help you. We have a comprehensive donor program. Anybody who's listening who's currently on the waiting list for donor sperm, we think that in the next month or so, we should have the entire waiting list eliminated. As I said, we have national and global connections. Also, if you look at the experience of our doctors, as I said, I believe strongly that the more experienced your doctor is, the less often they'll be recommending IVF for you. A good experienced doctor should be able to work out who will require IVF and in whom we can get away without the need for IVF. IVF is not a cure-all for all patients, and I'd like to think that most of our patients don't need IVF to get their babies. So experience is important, and as I said, I've been doing this for 25 years. There's 2 CREIs in Tasmania. They're people that have done the general ONG training, which allows you to be calling yourself a fertility specialist, but have gone on to do 3 extra years with examinations and research papers and training for those full 3 years in 100% in fertility care. We have 2 of those, myself and Manuela, who flies across from Melbourne. In addition to that, 2 of our other doctors, Emily Price and Stephen Bradford, have gone on to do Masters of Reproductive Medicine, which means they've done further academic study to get further degrees in this area. And Steve Sonovet, our other doctor, has, he's got almost 30 years of experience doing fertility care. So it's a very experienced team. We often discuss cases between us, so you know that whatever doctor you're seeing, you're not necessarily seeing just that doctor. That doctor's getting advice from other experienced clinicians. And another important thing there, sometimes you'll see your doctor and you think the doctor's going to be fantastic, but they just don't click personality-wise with you. And feel free to ask to see one of our other doctors that you might just click with better. The most important thing for us is that we get babies for you guys. And if it means just seeing a different doctor, that's no skin off anybody's nose. We're all very relaxed about that sort of thing. So we're the only team in Tasmania with further qualifications in fertility. We're a very experienced team, and we will be delighted to see you and help you achieve your pregnancies. Even today, one of our ladies been trying for 8 years, lots of problems, lovely couple, finally pregnant, and that's the sort of thing that makes this job and this work all worthwhile. So thank you for listening.